Good afternoon, everyone. Can you all hear me?
Yeah.
My name is Mark Hughes. I'm the co-chair of the Ethics Committee here at the hospital. Thank you for attending our next monthly session of Ethics for Lunch. Just to know that the Ethics Committee is committed to the idea of engaging the community about important issues. And the one for today about patient-centered care and shared decision-making is critically important. We have a distinguished panel. One of our panelists we're still waiting for. Hopefully he will arrive. But just to make sure, for those that are doing CME, we have the instruction sheet here. I'm going to introduce Zach Berger, who is an assistant professor of medicine and also a core faculty member in the Berman Institute of Bioethics, and he'll talk about our topic for today.
Thanks, Mark. Thanks everybody for coming. What I'm going to do is I'm going to read the case that we have today, and I'm going to talk about some general issues very, very briefly right after I read the case. And then we're going to go to our panel members to get their thoughts from their various areas of expertise and experience. And then, obviously, after they have their 2 cents, we're going to get your thoughts and questions as well. So the case is about risky treatment in suspected stroke, decision-making in a time-sensitive situation. And the case has to do, and this is a case that is suitably modified from a real-life case, in which an 82-year-old woman comes to the emergency room with right-sided weakness and aphasia. A CT scan rules out hemorrhage, and the emergency medicine team wishes to administer TPA, tissue plasminogen activator, a clot-dissolving agent, within the appropriate 3-hour window for suspected stroke. The patient's family agrees that if their family member is indeed having a stroke, they would favor treatment with TPA. However, the patient's family requests that further testing, such as MRI, be done to ensure that the patient will not suffer a complication from incorrect treatment, e.g. in case the diagnosis is incorrect and she is not having a stroke. These tests would be time-consuming and potentially result in missing the time window during which TPA would be indicated, thus losing the option of effective therapy. So just to lay out the specific issues in this case before we go to our panelists, on the one hand, we have the benefit of using TPA in embolic stroke, obviously dissolving the clot to improve the perfusion, the blood supply to the brain tissue, and thus improving outcomes in this patient with a stroke. And the literature it seems to indicate, and I would yield to my neurology colleagues for their detailed expertise, but it seems to indicate that the 3-hour window provides the greatest effectiveness, although there has been some recent discussion on the question of the exact time limit. On the other hand, should there be an error in the diagnosis and the patient's symptoms not be due to embolic stroke, but a stroke due to a clot, giving a clot-dissolving agent can, of course, result in hemorrhage. So those are the common pluses and minuses of a treatment in this situation. And 2 additional complicating factors are to be adduced here. One is that at least as implied in the case, and we'll talk about how clear that is, it might be that the patient in this situation doesn't have the wherewithal or is not in their fullest capacity to discuss the decision, and therefore it's the family that is discussing the decision. And second is the notion of time constraints. So all these general issues, benefits of treatment, risks of treatment, time constraints, and capacity of patients to engage in discussion about treatment options, and the presence of family members or other third parties are all issues that we, whether clinicians or patients or family members or other members of healthcare teams or situations, encounter quite frequently. So hopefully they'll be applicable to many situations. So we have a number of panel members that can explore this case from a number of avenues, and I didn't tell them who will go first, so this is going to be excitingly suspenseful for them. So my apologies. But I thought it would be very helpful, since this case is framed in a very clinical language, to get the thoughts of somebody that has really a lot of experience talking to patients and families in fraught situations where there's a lot of emotions in the case, even when pluses and minuses of treatment are being discussed in a clinical context. And Helen Michalsko is a very experienced social worker on the Ethics Consultation Service and has the amazing ability to not just comprehend complicated clinical situations, but to discuss them in the English language as if a normal person were speaking. So I was hoping that Helen could talk to us about this situation and like situations which she's encountered and how she might address and how she might, in a time-sensitive situation, understand the concerns of patients and family and discuss with them options and make them feel like their concerns are being heard, which, if you'll look at our questions to discuss, those are among the questions we'll be discussing today. So thank you, Helen, in advance.
Sure. So I wanted to turn it around a little bit. I can imagine that this is one of the most frustrating scenarios faced by a treatment team. You know what you need to do. You know what could benefit the patient, yet you're meeting some resistance from the family. And if any of you have ever been in our emergency room to see a bat brain attack coming in, it is quite impressive. The patient is placed in a critical care area where there are so many providers coming in the room, drawing blood, taking whatever they need, vital signs, running tests. The family's in the hallway. There's no place for them to sit. They're not sure who is in charge. And in a case like this, where the patient is pretty old, actually, it must be her children who are also old, and all the providers look very, very young. These are not the providers of this patient. This is not the normal healthcare team for this patient. The people who they have trusted, nurse practitioners, PAs, physicians who see this patient in the community. These are a bunch of strangers. With multiple levels of providers coming in to speak to them, to give them their opinion, ultimately everything may be the same that is being said, but said in a little bit of a different way, so it causes some confusion for them. If they're not very sophisticated medically, and I think most people are not in this situation, it is even more frightening. The fact is that they're looking at someone that they love, who is vastly different than that person was just an hour ago at home. And we don't know what she was like. They don't know to trust anyone. They don't know who to trust. Someone coming in and saying they're a third-year resident means nothing. They're looking down the hallway and there's some nurses laughing about something else. And in the next room there's 4 city police officers with guns strapped to them because someone is shot. Housekeeping is sitting 2 doors down, talking about what they're going to do this weekend. So it looks like an uncontrolled, chaotic situation. One of the biggest problems is that nobody ever sits down and touches people. It's all done standing up over the bed, talking over the patient. Maybe she can understand, maybe she can't, but I think every attempt should be made to at least try to engage her, to see, give her the respect to see if she can understand. You cannot discount the importance of sitting down with the family, perhaps holding hands, saying, tell me what Granny was like. Who is she? Building some relationship and some trust. Helping them understand that you have the patient's best interest at heart and that the decision you're making about what treatment plan is based on many, many years of very scientific experience. It's not guaranteed that it's going to work, but it will help, I think, a bit with the resistance and some of the anger these people may feel.
Thank you. And I want to emphasize why that was so important to hear, because in a case like this, oftentimes the emphasis is placed on the decision-making, which is what I emphasized in my opening remarks. That is, there are risks of a treatment and benefits of a treatment. And what we're discussing is how to make a decision in that case, how to choose one of those options. And what Helen pointed out very importantly is that oftentimes the decision is not precisely the least of the worries, but sometimes immaterial or pales next to the emotional component and the dislocation and the dehumanization of a healthcare experience. And so one common model to apply to decision-making is something called shared decision-making, which many of you might have heard about. And there are many different models of decision making, but in this day and age, shared decision making is a very powerful and often cited kind of model, in which, according to which precise wording of the model you hold by, the clinician brings their expertise as far as the treatment's pros and cons, and the patient brings their expertise regarding their values and preferences and what they find important. And the two work together to find a treatment option that works for the patient. And that is very important, and I would like to push us in our institution towards that. But on another level, things don't work that way, as someone points out, because the very nature of the environment itself works against decision making. And what's primary to a person is how they're being treated as a person, involving primary ethical virtues like respect and dignity and ability to express oneself as an individual. And all those things have to be taken into account as, or even before, we talk about discussing pluses or minuses of given treatment options. So often, in a healthcare setting, we, and I speak as a clinician, are incentivized or are driven to make decisions about what is to be done, whereas oftentimes the priority is not necessarily what's to be done in a clinical way, but what's to be done in working with the patient and the family. And so to further speak to that issue about what it's like, which I think is so important, understanding what it's like to be in that situation. I wanted to invite Carol Sims to give some thoughts, and she has great experience talking about the patient and the caregiver experience.
Hi. So, first of all, in this case, I think a couple of things jumped out at me, and one of them was, why is the family asking for an MRI? And why are they uncertain as to the diagnosis? So is it a matter of they haven't been communicated with as far as a certainty of diagnosis? Is there confusion among the team, which would lead to further insecurity on the part of the family? And I think that there is a very high learning curve, you know, when you're in this kind of a situation, which is so time sensitive. And to Helen's point, I think kind of bringing in the family in a way that maybe has less to do with an absolute decision as it does with understanding the questions they may have. So for me, the question I would have is if we don't give TPA, what does that look like for my loved one? What do we gain from an MRI? Why was this even, as a patient, why, you know, or the family of the patient, why is that even brought up as a possibility? I can tell you that I have been in many situations where in a teaching situation like you have at Hopkins, there is confusion for the patient. You want to share in the decision making, but you're hearing a lot of different things going on around you all at once. You're hearing a lot of people ask questions. You know, you're hearing residents ask questions. You're hearing students ask questions. You have different docs saying different things, and then you compound that by being in the emergency room, as Helen said, and it becomes pretty confusing pretty fast. I was recently in a very similar situation, albeit not with an 82-year-old, but a 48-year-old friend of mine who had just this situation, and where they were trying to decide whether to administer TPA, not based on was it the correct diagnosis, but based on the time that the stroke had started. They weren't unable to ascertain that. But they took the time to try to ascertain that. So they talked to me, they talked to people that were around it before, they got people on the phone. I mean, they really took the time to find out the scenario within which this stroke has taken place. They didn't feel rushed. This was not at this hospital, but they did not feel rushed. They were very aware of the time limit, but in their speaking to my friend's family and to her friends, it was a very considered kind of time frame that they took to gather all the pieces together. And they also did exactly what Helen was saying. We were not in the hallway. were brought into the room, who were given chairs. Everyone except one doc was sitting. They were engaging with the patient as well as with the family. It was very, very well done. And still, ultimately, the question came down to the family saying, what would you do? What is your best recommendation from the doctor? Because I think there are times when we, as patients and family, we want to know exactly what's going on. We want to feel like we're in the loop, but we aren't the doctor. So we want to feel secure that diagnosis is correct, number one, and we want to be very aware of the side effects of whatever you're giving, or what happens if we're out of that 3-hour window, then what? And one of the things the doctor said was, well, we could have a bleed. And there was a blank stare on my friend's family, their faces. So I looked at him and I said, okay, describe that, what kind of a bleed? And he goes, oh, a brain bleed. I said, okay, and what happens if there's a brain bleed? He goes, oh, well, that's catastrophic. So then you could see realization kind of, dawn on the family, and they're saying, okay, well, no, we're not going to do that. But I think just taking that time to tease out the specifics and give the space to ask the questions, even in a situation that's time sensitive, and to help the understanding will really help everybody reach consensus.
Thank you. Thank you. I think teasing out the specifics and discussion between the clinician and the patient and family is obviously very important. And in a time-sensitive situation, it becomes tricky exactly how to do that. And although I'm not a clinical expert in this particular situation, I will say that one question that I imagine came up in this case or in other similar cases is various sorts of what if. For example, what if we waited more than 3 hours, right? What if we waited 3 hours and 15 minutes, right? What if we didn't get the MRI? What if the TPA didn't work? And there are lots of cases in which I, in my internal medicine practice, face situations where I don't know the answer. And to my mind, it's important to not abandon the person you're speaking to if you're a clinician. It's important to give them as much information as you know and provide them with a sense they're being listened to. But also, I think another virtue to pursue in this sort of thing is honesty about what you know and don't know. And there are many times in medicine where algorithms are encouraged to promote quality of care. But we also know as clinicians and also as patients too that sometimes the algorithms, there's always spaces in which it's not clear how the algorithm applies. The patient is 3 hours or 3 hours and 30 minutes outside of the window due to the TPA. Now, again, I'm not a neurologist, I'm not an emergency medicine provider, but I imagine that's occasionally a question, just as what happens if you're outside another sort of window, and what specifics matter most. And sometimes the science behind the algorithms is not as clear as we would like to think, and I think we all know that. Then the question often comes about, there's the emotional valence, right? How do we best, as families assisting a family member, or as caregivers or as clinicians, how do we best acknowledge the person's emotional needs? How do we best, as clinicians or patients, understand the informational pluses and minuses? And then there's the question of what we should do ethically, and then what we have to do legally. For many years, the well-known standard has been informed consent, and then there's the question of whether that standard will or has changed. And so Jack Schwartz, with legal expertise in these matters, will speak on that.
Hi. Let me do a standard disclaimer. I'm not counsel to Johns Hopkins or anybody here, so this ain't legal advice.
Never mind.
Many of you will remember the old SAT with its analogies. A is to B as, and then there was multiple choice, J is to K, X is to Y. So here, informed consent is to shared decision-making as, and the correct answer is Bud Light is to craft brewing IPA. And the law is Bud Light. So the law is informed consent doctrine, not shared decision making. Maybe it will be, but at the moment it's informed consent doctrine. I think that informed consent is predicated on a two-step process of decision making with an intervening one-way flow of information. That's the sort of historical roots of this as judges made this kind of law. So the first step of decision making is the physician decides on the optimal therapeutic response to the patient's illness. So this is based on the physician's expertise and the rubric of standard of care. And the moral context is one of beneficence. So the physician is seeking to promote the patient's welfare and avoid unnecessary harm. In this case, through administration of TPA after the CT scan suggests that, I assume this is clinically correct, that it is much more likely than not that the stroke is ischemic rather than hemorrhagic, given the CT results. So then the physician seeks consent for the treatment and provides the information sufficient to make the consent an informed one. That, in the grand scheme of things, is a relatively recent development. Prior to the rise of the informed consent doctrine in the 1960s and 1970s, the only obligation was to obtain consent. There was no duty as to the informational component. There was a duty with respect at least to invasions of the body to obtain consent, bare consent. And here the moral context is autonomy, so respecting the patients, or here in this case the surrogates, as moral agents. And then, so there's the physician's decision, there's the intervening flow of information, and then there's the patient's or surrogate's decision, which is to say yes or no to the proposed treatment. And this particular case is complicated by what seems to be a neither yes nor no response by the surrogate in the context of significant time pressure. People may have, when they read this case, thought, why are we worrying about consent? Because this is an emergency, and the emergency doctrine means there isn't a need to obtain consent. That's not quite right. If the patient lacked capacity and the surrogate family wasn't around, then yes, the physicians would be authorized to carry out their clinically appropriate intervention, namely TPA, without anybody's consent. That's the core of the emergency doctrine. But even in an emergency, if the patient has capacity, one is supposed to seek consent. If the patient lacks capacity, but a surrogate is available, the physician is also supposed to seek consent. So it's not that, oh, there's an emergency and let's forget about consent. It's that there is an emergency coupled with the absence of anybody who can give consent. That's the encapsulation of the emergency doctrine here. So the very act of seeking consent implies that the choice of no is available. If the choice of no is not available because it's wholly outside standard of care, don't ask. Presumably you're not going to ask for consent to stop active bleeding from a wound. Oh, should I apply pressure? Let's talk about that. No, I don't think so. So stay within standard of care. If not doing the intervention, if not using TPA under these circumstances, at least until further diagnostic information, if that's within standard of care, then the informed consent process, framed as, is it conceivable that a rational patient might delay TPA administration in order to gain further diagnostic information? If, yeah, it's within the range of possibilities, then, okay, this sequential informed consent process ought to go forward. In theory, the informed consent process is supposed to include a presentation of alternatives, which is central to shared decision-making. There's plenty of evidence to suggest that that's just a formality, that's not real, that there's really just a proposed treatment and information about that and the risks associated with it. And alternatives get pretty short shrift, typically, in the informed consent world. So taking shared decision-making seriously might transform informed consent from what is too often an empty ritual aimed at protecting the physician against liability into a genuine conversation. But that's not the world now. Nobody has a legal obligation to engage in shared decision-making. Physicians have a legal obligation to engage in the informed consent process. Could the rise of shared decision-making change the legal framework? Posing that as a future possibility. Yeah, it could happen. There's one rather straightforward way in which that could happen, and that is to put shared decision-making concepts into a statute. In Maryland, amend the Maryland Healthcare Decisions Act to include a shared decision-making option. That's what's happened in the state of Washington. That's what the Washington legislature did. So there's a statute in Washington that has certain key features. It defines what shared decision-making is. It frames it as an alternative to standard informed consent. So, in other words, the patient is asked to consent to shared decision-making in lieu of normal forms of informed consent. The provision in the state of Washington recognizes that the use of patient decision aids is, if not inevitable, at least a favored component of shared decision-making. And so it recognizes that, but it says these patient decision aids should have undergone some kind of recognized certification or evaluation process, as opposed to just coming up with whatever you think would help the patient or family understand this. And then the Washington statute provides legal protection, a kind of immunity, protecting the discretion whether to use shared decision-making or not. In other words, it's placed out there as an alternative, but nobody is required to do it. So if you like that approach, well, the Maryland legislative session is, what, 2 months away. Start building your coalition now, get your professional associations in gear, make it a priority, get some patient advocacy groups on board, and then it'll fail. But you got to start somewhere, and so maybe it'll pass 3 years from now. Get started now if you like the idea of having it in law as in statute. The other possibility would be that courts might incorporate aspects of shared decision-making into the informed consent doctrine itself, which is, after all, in Maryland and most places, a matter of judge-made law, of common law. The common law is like a reef, a coral reef, and it can have accretions to it. This could be one. First of all, current law does not require actual evidence of patient understanding. The informed consent form, when there is a form, often includes a rote recitation, yes, I understand, yes, I've had an opportunity to ask questions, and that, in most circumstances, is completely bogus. It's just a formality. Now, done properly, shared decision-making does seek evidence of genuine patient grasp of what's going on, of the proposed treatment and the alternatives. So this could become an additional element of legal informed consent. It's not now. Secondly, there's the time element, which is part of the problem of this case. I think it's no accident that shared decision-making, as I understand it, has largely arisen in circumstances where there is plenty of time. So I'm diagnosed with prostate cancer. So okay, so now I've got a choice of things that could be done. Shared decision-making is a very useful modality to help me understand, should I do the surgery, should I do the radiation, should I do watchful waiting? But there's time for that, or at least a little bit of time in most cases for the implantation of the cardiac defibrillator or whatever. So it allows time, and that's good. Informed consent doctrine doesn't have a time component built into it. That's why sometimes informed consent occurs in the 15 minutes before the procedure, just before the anesthesiologist is going to inject the propofol or whatever. So that's also a practical objection to shared decision-making, by the way. Docs don't have time. But anyway, theoretically, this could be an additional element of the legal doctrine of informed consent, though it would be very hard for the courts to figure out how to frame a clear and feasible time criterion. Informed consent doctrine in Maryland and many other states has a so-called objective standard for what counts as a, quote, material risk. That's a key aspect of what is supposed to be part of this information flow from physician to patient. What are the material risks involved here? And that is, this objective standard, is whether a reasonable person, that lawyers and judges love, the genuinely non-existent in the real world, reasonable person. But anyway, would a reasonable person in the position of the patient have considered the risk to be a material one, meaning one that might have changed the ultimate decision? If so, then it is a material risk weighed against this objective standard. By contrast, shared decision-making is focused on the informational needs, the values, the preferences of this individual patient, not some hypothetical reasonable person in the place of this patient, but this very individual. That's the point of it. That's the point of the exploration, right? And the point of the conversation. So you could at least imagine that the common law informed consent doctrine could shift toward a more subjective standard about the adequacy of disclosure. I'm not predicting these changes. Courts tend toward caution in changing important common law doctrines, but it is possible. I mean, it was a big deal to shift from just consent to informed consent. And not as big a deal, but still noticeable. Like about 5 years ago, the Maryland Court of Appeals, the highest court of Maryland, made it clear that the informed consent obligations attach not just when you're going to do some invasion of the body, but to all manner of treatments. So it's possible. I'm not saying anytime likely, but what I do think is the more that shared decision-making becomes a part of medical custom, the more frequently it is the case that physicians actually do this, especially among Maryland physicians, the more likely it is that the courts in this state would be open to the possibility of incorporating some of these shared decision-making notions into the traditional and now much more limited informed consent doctrine.
Thank you very much, Jack. Thank you for the reminder that painstakingly built coalitions can fail. Before we go to comments and questions from you folks, I wanted to, and that was great because we got a brief accounting of what shared decision-making entails. It entails laying out options that have clinical equipoise, that is, they're equally available to the clinician and they're equally justified by the evidence, and taking account of the patient's values and preferences, letting the patient know they have the ability and are empowered to make a decision, and then helping the patient carry out that choice. And there are various steps enumerated in different ways in the literature. A link was provided with material that gives a good introduction. But I wanted to ask both Helen and Carol, so we talked about how the clinician might go about shared decision-making, and oftentimes this involves a decision aid, often an online tool. But a tool can be used in a patient-sensitive or non-patient-sensitive way. And so I wanted to ask these folks, if you had to begin a conversation talking about options, what would be the best way to start? It's sort of an impossible question because it's a particular case and the opening might change, but since, maybe I'll ask Carol if there's a good way to start off a conversation like this.
So you're asking me, if there's a good way for the doctor to start off a conversation like that? Well, to me, and I've been lucky to have doctors that have brought me into decision making. So for me, it was always an acknowledgement that I had a stake in the outcome. And I would ask you to think about the outcome sort of differently than you would think of it as a clinician, right? So the outcome for the family and the patient entails a whole lot of things that aren't about a snub plot. And so the ramifications of these decisions extend far beyond the walls of the hospital. And once you're satisfied that you've done the best you can, the patient and the family is left with their outcome. So I think to say to the patient, we want to make the best decision we can for your loved one, if you're acting as a surrogate. I think to start with that acknowledgement that we want to make together with you the best decision we can for your loved one is, and don't say what questions you have. Don't start with that. Half the time, a patient has no idea what questions to ask. None. So you start with saying, how are you feeling right now, and what are your goals? What do you want us to try to achieve in this situation? I think that if you start there, that acknowledgement goes a really long way to then laying out, so then I would say, well, tell me what this treatment you're suggesting will do. What's the benefit? How does it work? What are the side effects? All of those, then I can start the conversation. How will my mother be when I take her out here if you give the TPA? That's the other thing, how am I going to take care of her if we don't administer the TPA? What are going to be the eventual outcomes that are going to affect me, her, and our family? So, but I think just bringing that sort of we language in, even if ultimately hold all of the sort of experience and intellectual capacity and knowledge of prior situations, to acknowledge that this situation is important to the people sitting in the room. I think that's a good way to start.
Thank you, and I'll add to that in thinking about decision aids, which Jack mentioned, are often used to supplement or to make or operationalize shared decision making. Very rarely have I seen, I don't know if ever, have I seen that the first step is to specify what the patient's goals are or the family's goals, right? Oftentimes in the decision aid, you start with describing what the treatment options are. So it'd be interesting to think about flipping it on its head and using or finding decision aids or making them if they don't exist that start with the patient's goals first. Ellen, do you have thoughts on how best to start a conversation like this?
Again, I think trying to humanize the situation a bit in speaking either to the patient or to the family and saying, tell me what you're thinking right now. Tell me about yourself. What were you like before this happened? Helps them understand that there are consequences. And maybe those discussions have been had with this elderly woman in the past with her family, and she's very clearly given them an understanding of where she wants the line drawn. We often wait till it's too late and therapies are started and very invasive things are going on before we're able to try to put a stop to it, and it's too late at that point. But the shared goals are great. I think goals of care are just something we're coming into these days that are vastly important.
Sam, could I just interject something that, well, I certainly don't disagree with what was just said. It seems to me that fairly early in such a conversation, and it may be understood as a goal, is to find out whether the patient or the family actually wants to participate in shared decision making. Not everybody does. Some people just want to trust their doctors and don't want to deal with the burden, because it is a real burden that comes with this. So just as you would try to differentiate between the patients who want lots of information and those who want less, kind of a judgment call based on your probing about this a little bit. So I think it's worth early on not to assume that people want this mode of decision making.
The story I always tell, I love the story, so I'll tell it before we ask for your questions and thoughts, is I have a patient with paroxysmal atrial fibrillation where it's unclear whether he should be on anticoagulation, be on blood thinner. So I took him through a couple of decision aids. We had an exhaustive discussion. I asked him what he wanted. He looked at me and he said, "It's on you, doc." So this is what he pays me for, right? So it's important to know what these preferences. Maybe we can get questions from you folks or comments. We have our Vanna White.
Okay, so it just occurred to me as we're talking talking about shared decision-making, if you're taking this doctor who's like steeped in medical knowledge, and then there's the lay person who may have no medical knowledge, and there's this huge gap in between, which was kind of demonstrated with that example of what does leading mean. So it's almost like you would also need an English-to-English interpreter somewhere in that scenario.
Well, I can say that that's very true. You know, there's nothing more disconcerting than have somebody come in with all that knowledge and throw it at you, and you have no idea what they're talking about. And I would say especially there are a lot of situations where somebody does not feel comfortable then asking the question, what do you mean? They don't want to appear stupid, ever. So I do think language is really, really important when you're in these very difficult situations. And I do agree wholeheartedly with Jack that there are some situations where you don't have the knowledge, and you could say, I don't have the knowledge to make that decision. I want you to make it, you know, doctor, that's what I rely on you for. But that's a huge gulf. That's a huge gulf. And I think recognizing that and trying to, if the patient is exhibiting or the family is exhibiting a want of understanding and needing to know that the doctor, the clinicians have to take a step back and think how to articulate this in a way that is understandable and that truly is informing the patient.
In theory, patient decision aids can help bridge that gap, both in terms of comparative, the imbalance in knowledge and the difficulty of understanding the language.
And I will say that my microphone decided to lock me out.
Here, here. You can use mine.
Block me. So I will say that although information asymmetry, which is the term that people use, is important. You know, the doctor often knows a lot, the patient often doesn't know so much about a given clinical situation. I think sometimes that's a myth for two reasons. One is that medical evidence is not as perfect or as unchanging or as reliable as many of us are led to believe. Right? You could look at the articles of John Ioannidis or anybody else about the biases in clinical trials, ranging from pharmaceutical company bias to investigator bias to publication bias. All sorts of things render science imperfect, and we all know that. So that's one thing to realize, that sometimes when a doctor says they know something, they might be wrong, and that happens pretty frequently, right? And then the other thing is to note that there is an information asymmetry in the other direction. A patient knows about themselves in a way that the physician does not. And that knowledge might matter just as much as the trial results. So there's an information asymmetry in both directions. There's also an emotional asymmetry. So it's important to keep all those things into account.
I just want to add something in my 120 years of working here. It seems that way sometimes. I have often, I've covered the emergency room in probably every area of this institution, and I would suggest that you develop relationships with your ancillary staff, because I will often take on the role of the stupid person, a role I play very well, and will listen to the physician's presentation to the patient and family, and you know, you can, after a while, you can start seeing people where you're losing them, and I will say, gosh, I don't understand that, can you explain that to me? Because the family or the patient may be too afraid to do that. So start, you know, working, use what you have available to you in the different areas, it really does work.
Next question, maybe if Peter can find.
Very good discussion. I have a question about, it was alluded to a little bit, the difference between the emergency situation and the non-emergency situation. And the example that was chosen for this panel is an emergency situation, so it's clearly not a situation of prostate cancer. You can sit down and have an hour or a couple of days to decide what to do. So I think that while it's important, and I do support shared decision making and we strive to move towards that. I think it's important to also recognize that we have a limited amount of time. And unfortunately, some things like gunshot to the chest, everybody would assume, please do something. And the shared decision-making takes a back seat. And medical treatments may be more prone to people thinking, okay, we need to really discuss this, but it may be equally sensitive in terms of time. So that's one aspect that I appreciate a response to that. But related to that is, if the bar, I mean, we definitely want patients to understand, but if the bar is understanding, what happens when we reach an impasse and the patient does not understand, even though we have done everything. I'm not talking about disagreeing or not wanting the treatment, but actually, plain old, I don't understand, I don't know what to do. If it's a time-sensitive decision, what do we do in that case with this model?
I guess I can
start with the first, and that is, I think it's obvious that the danger of shared decision-making becoming a buzzword is that people throw it around, like it's the latest thing, and people lose sight of what it actually means. And the fact is, it's obvious there's a spectrum, right? There is a spectrum of cases, and when someone is hypotensive and is febrile and warm to the touch, and they need fluids, you're not going to ask them if they need fluids, right? You're going to do that thing that, if you're a clinician, you're trained to do. So obviously there's a spectrum. There are things we know that we need to do, and there are things that we know we shouldn't do because they don't work. But there's a vast gray area, and I think oftentimes, especially under the financial incentives of an academic medical center, we're under the impression that we need to do something, that something is clear. But sometimes it's not clear what to do, and we need to deliberate on what to do. And so, yes, there is a spectrum, but sometimes we need to realize that that spectrum exists. And I'll yield to my other panel members about understanding. Sometimes people don't understand, but I think it's really hard to get at what someone understands and how, and asking someone, do you understand, is very rarely a helpful question in my experience, right? And maybe Carolyn and Helen can speak to that. Yeah.
So it's all a matter of how you form words. You hear around here, we're going to do this, okay? Patients are like, yeah, sure, but I don't know. I think using the old standby of, explain to me what you just heard me say. Try to tell me what you heard. Give you a little bit better idea of your understanding. And what you do in a situation where there is absolutely none, gosh, that's a physician decision that I'm glad I don't have to be in a position to make. Right back to you.
I think that, yeah, there are times when people truly don't understand, but I probably think those are fewer than you think. And the flip side as a patient is you never want to feel like the doctor is abdicating their position to you, and yet you want to feel a part of the process. And I think that's a tricky thing for doctors in a very pressurized situation that may or may not have people that you perceive as being understanding or knowledgeable or intelligent or able to think in their emotional situation. I would caution against that a little bit in the sense that I have seen in ethics consults where we have gathered the throngs of intelligent doctors and clinicians and of all stripe to look at a complicated case for, in this instance, I'm thinking about a 17-year-old girl who had a baby with a trisomy, I don't know which one it was, but at this point. And because of the siloed situation, one doc was saying he could do this, and another doc was saying he could do that, and yeah, I could do this for this baby, and I could do that. And when you got them all in the same room, she was very quiet, and it became clear during the conversation that this one really couldn't do this unless that one could do that, and which one would go first, and then ultimately what was it going to garner this baby. And she sat very quietly with some tears running down her face, and at the end, She looked at everyone in that room and said, I have made my decision. We are not going to do any of these things. I want to live out my days holding my baby as much as I can, and we'll deal with what's in front of us. And I would like some genetic counseling, please. I thought the jaws were going to drop all around the table because nobody anticipated that she was absorbing all that and understanding what was being said. It was sort of one of these conversations that was going like this. And I learned a huge lesson that day, is that the assumptions we make are sometimes very, very wrong. And that there may be these cases where somebody truly doesn't understand, but I think you have to give it a chance. And if you don't, then that is a disservice to everyone.
I guess finally I would echo what Helen was saying about having them teach back, say what they understood, but sometimes the way that's worked for me is to say, tell me what you think is going on, or tell me what's going on here in your own words. What are you feeling? And sometimes they might understand it, but they're understanding something different than what we're understanding. And can I also thank Peter Young from the Berman Institute, as he finds question askers, for all the efforts he put into this panel. So.
I wanted to ask about two elements. One is uncertainty, so diagnostic uncertainty in this case, where I think the family's desire to get the MRI is to try to build a case that they want more certainty in order to make the right decision for their loved one. So that's one aspect of both the clinicians dealing with uncertainty and then the families having to deal with uncertainty. And then the other is risk and risk aversion. Clinicians might have a different threshold for taking on risk, and then families may have a different threshold. So what happens with those two aspects when you're having to make these either shared decisions or informed consent decisions?
So one way of approaching that is to understand there are different types of uncertainty. There's uncertainty that has to do with things being very complex. There's uncertainty that has to do with things being expressed with probability. What's the chance this person will miss a field goal? There's a chance that has to do with things being ambiguous, where it's really not clear what's happening. And sometimes all those things overlap. So sometimes you can actually reduce uncertainty through effective risk communication. So sometimes it does happen that, just thinking of something I encounter pretty frequently, if someone wants to know what the risk is for a heart attack, and you display things not in terms of numbers, but in an icon array, with 100 people and 98 of them are green and 2 of them are yellow, something like that, displaying risk in a different way. And so sometimes that can help reduce the uncertainty. Sometimes you need to have recourse to specialists that can estimate if you got the TPA, your chance of diminished function would be reduced by this much. Sometimes that can happen when you're speaking to an expert. So those are two ways of going about it. But I think a third thing to realize is sometimes uncertainty is irreducible. And there was a recent article in the New England Journal of Medicine that talked about uncertainty as an omnipresent or irreducible aspect of healthcare. That sometimes you're never going to know. And so part of it is communicating what the clinician can say numerically and with pictures and with ways that make things easier to understand. And part of it is to be there with the patient and family and caregiver and say, we're going to do what we can. It's a difficult situation. Things are uncertain. And to acknowledge that. So two directions to go. And I wonder if there's a legal aspect that Jack can address here.
I think traditionally the law's not done a very good job of acknowledging uncertainty. Perhaps it's a form of homage to physicians. Judges think that physicians are more certain than sometimes they are. So the informed consent doctrine would accommodate uncertainty, which is to say, one might characterize uncertainty as a form of risk, but it's not generally understood this way. Instead of we're not really sure. Things tend to get translated into characterizations of magnitude or likelihood.
There's a small risk.
Yeah, there's a small risk of, and historically the law has been very comfortable with that way of, as it were, dissolving uncertainty into an adjective.
Except when you ask clinicians about what small risk means, the literature shows there can be a factor, order of magnitude difference, because between what one person thinks is small and another person thinks is small.
And I do think patients do respond well to doctors being honest about their uncertainty. My father had an emergency aortic aneurysm, and as the surgeon's like running out the hallway with the gurney, he's saying to me, "I'm not certain what this outcome is going to be. I don't know enough about it yet. I will do my best." And that's all anybody can ask for, really, in the end, is that you do your best. And just, instead of just grabbing my dad, first of all, I ran down the hall to get him instead of waiting for him to come up. That, to me, spoke volumes. Secondly, he took that time to have that brief conversation with me. And that meant the world. So I knew he was in there trying the hardest he could to save my father, and he did. But it was, you know, it didn't make me any less afraid, but it made me know that the person was being wholeheartedly working on my father's behalf. So I think the uncertainty was okay and was mitigated by the fact that there was this effort being made.
From a patient or family perspective, which I've had some experience, there's an additional uncertainty that comes from fragmentary information in a setting like an acute care hospital, where, so especially from the family's perspective, say you're looking for strands of hope. And so this doc says one thing about, oh, the kidney's looking a little better today. And this next doc 2 hours later says something else and something else and something else. So from the patient or family perspective, there is the uncertainty that comes from being bounced from optimism to pessimism and not being able to understand how this glob of information fits into a larger picture. One potential virtue of shared decision-making is that it, at least in concept, would mitigate that because it ought to be a process that better integrates all of the relevant information instead of leaving patients and families to the mercy of which resident says this.
Okay, any other questions?
Well, thank you. I'd like to thank all our panelists for their participation. Again, thank you to Peter Young for organizing, to thank the Berman Institute faculty members that have, Dr. Himmelstein and Dr. Hughes and others that have helped put this together. So thank you very much for coming.